Welcome. For this session, we're going to share about one of our research efforts in transitioning message mapping guides to the FHIR implementation guide. We'll provide you with an overview of what the project is all about and what we're trying to do, as well as where we are now with the project. So for a little bit about us, I am Tia Pope, joined here by Myung Choi, where we are representing the Health Interoperability and Security branch of the Health Emerging and Advanced Technologies Division within GTRI. We both lead in this area as the Director and Senior Research Engineer and Architect. I would like to first share what the message mapping guides are and what we have learned about them. Message mapping guides, also known as MMGs, were created to describe the data content needed for HL7v2 case notifications for national notifiable infectious diseases or conditions. MMGs have played a major role in helping the CDC to understand diseases, their spread, and determine appropriate actions to control outbreaks as part of their case surveillance strategy. Case surveillance occurs each time public health agencies at the local, state, or national levels collect information about a case or person diagnosed with a disease or condition that poses a serious health threat to Americans. Jurisdictions across the United States use MMGs to capture the answers to questions needed by the CDC for public health surveillance. In the image above, you can see an example of those questions for COVID-19 surveillance. Questions such as, did the patient have any underlying medical conditions or risk behaviors, are especially important to capture for illnesses like the coronavirus that is said to spread more easily and leads to a more serious illness than the flu. That being said, we discovered a few things about the MMGs that provided us with an opportunity to help improve this surveillance process. We learned that each program in the CDC defines its own MMG, which makes it a challenge to scale the guides. This could also lead to longer lead times for defining a new disease in the MMG format. Since the MMGs are highly dependent on specific programs rather than the data elements themselves, it can at times lead to the duplication of surveillance efforts and thus impact the timing of finding potential health threats. Our goal for this research effort has been to map the legacy mapping guide to the more advanced FHIR implementation. Another goal is to develop a MMG FHIR IG, which could support backward compatibility while making this portion of the case surveillance data flow more scalable. This, of course, is no small feat. The mapping has and will continue to take a lot of manual mapping from HL7v2 with the MMG customization to the FHIR implementation. But once we complete our research from that regard, we can then do more widespread testing with the community as part of the IG efforts. As we transition the MMGs to the FHIR IG, our solution is set to be data element based rather than program specific. We intend on utilizing profiles as a way of defining those common questions required by CDC for surveillance. By focusing on the data elements, we will be able to collapse questions that may be repeated across the messaging guides. This will help make the process scalable and reduce duplications. The profile approach will also support CDC programs in their composition of disease datasets, providing them with consistency from the start. As part of our research, we are also exploring all options we can within a limited amount of time, including the utilization of existing standards such as ECR FHIR, US Core, US CDI, and so on. All of these concepts will help lead to faster data collection with a more modern interoperable approach, which will make it easier to capture the data the CDC needs for new diseases. Now I would like to hand off to Myung, who will share more about our mapping approach and how we design our converter.
Thank you, Tia. Data element mapping is a key part of transitioning processes. MMG maps a list of questions to HL7 version 2.5.1 data structure. Each question is assigned with a V2 segment and data element identifier. And for each data element, answers are associated in an appropriate data type. Jurisdictions answer the questions using MMG based on data they captured, and messages packaged in HL7 version 2.5.1 are transported to CDC, who is the consumer of MMG. As a first step, we mapped the data element identifiers to FHIR resources. Most of the mappings will be one-to-one using observation resource, and we use this one-to-one mapping as our fallback and default mapping. However, there are some data elements that cannot be mapped with one resource because of its dependency. Furthermore, FHIR is designed to cover clinical information. Thus, it is possible that one resource can contain enough data to answer multiple questions. For this reason, as a second step, we linked FHIR resources that are mapped from one data element using resources like patient, diagnostic report, and so on. We also evaluated questions to see if we can group data elements into one FHIR resource. We found that if we preserve the original upstream data in FHIR and pass them along with the other mapped resources, they can be used as a good supporting material. Our final step is to profile the resources, link them accordingly, and attach answers with the standard value sets. Ultimately, this will become a FHIR implementation guide for MMG. This allows not only mapping the traditional data, but also more clinical data that were not available in MMG. And to avoid sending too much data, the IG profiles can guide CDC programs to narrow down to the information they need. Georgia Tech Research Institute has currently completed several MMG mappings, which are GenV2, HAI, STD, lab repeating group, case notification panel, etc. This is the first step of mapping. Spreadsheet and UML-like diagrams of the mapping are composed as shown on this slide. The first step of mapping is done case-based, so that the mapping can support the legacy system. Thus, mapping was focused on maintaining and persisting MMG data. Since there are many custom questions and type, this mapping uses many extensions. This mapping will act as an intermediate mapping, as profiling and linking are done on the mapped resources, and as cultural shift from MMG to FHIR happens, the mappings in FHIR IG will become more mature. For one-to-one default mapping, which we call straight no-brainer mapping, we used HL7 version 2 to FHIR project. Using this V2 to FHIR mapping project and our MMG mapping, a converter tool is developed for the lab repeating group. We are currently in a preparation of IG development and will soon begin profiling the data mapping to a resource. For the case-based mapping, we designed a V2 segment-based state machine that can be used in the mapping converter. This state machine follows the V2 message segment flows in the message pipeline. At each resource state, data element identifier directs the mappings to FHIR resources. All the states in the state machine can be configured at the runtime. Thus, this design can support the future or modified MMGs without rebuilding the converter software. Because the converter design is based on the V2 segments, by extending the segment triggers and the resource states, the converter can be used as a general V2 to FHIR converter. Now, I'd like to hand over to Tia to wrap up our presentation.
We actually have one more piece before we close. I previously recorded a demonstration of the walkthrough that you led of the converters. So let her rip.
I'd like to demonstrate our converter that was developed for the this MMG to FHIR mapping project. And this converter can convert or transform the V2 lab repeating group in MMG to FHIR bundle. And this, what you see on the screen is the our source code that is posted on the GitHub site. And we can see like other kind of versions here, but our main focus is 2.5.1 to R4. So I'd like to show you how it works. So this is the backend server that listens to the HTTP port. So this is like a V2 over HTTP applications. And this parser can actually have another server which can listen to MLLP, which is like another lab transport protocols that labs are sending over. And this is the Java Maven project program. So for testing, we can use Jetty server. And this is a Word file. So this can be deployed in any like a Java application server, such as like a Tomcat kind of stuff. All right, so this is running. Now this folder is supposed to have the FHIR data that is converted by this server, and this is empty right now. And I have V2 UI program that is developed by happy people. So this file, this V2 message that you see on the screen, this is a TBL TBI MMG message. And if you see this the message segment header, we can see this is like a TB data MMG here. As you can see, like we have like some MMG related data in here. So this is validated, so this is fine. It's, this has no error. So we have like PID sections and OBR and OBXs. We have all this data here. So what I'm going to do is I'm going to send this V2 message to our computer, and this is running on the local machine and listening on the port 8080. So I'm going to send it. Now it's sending it, and you can see in the log window, this is receiving the data. And now if I scroll up a little bit, I can see the response, and response, I have an acknowledgement as a response, means it's successful. So I have the data in. So that means I should have output data here. So as you can see, we have two data written by the server. The reason that we have both is the happy server that we are testing with, it was not able to consume the message bundle. It was able to consume the transaction bundle. So I'll show you how it looks like. So I will open this file. So I'll show you the message first. So this is a message. I'm going to all right, so I have to change this to a JSON, and then I can go to the package and make it prettify. All right, so it looks good. So now we have some of the extensions, as I said in the slide in the presentation. We have like a number of extensions to support MMGs. I will collapse that so we can see others. We have a diagnostic report here, and we have service request, which is I think coming from OBR, and we have observation, which is OBXs. So we have like a laboratory, we have a country of birth, and we have like all these MMG related questions, like country of user residence, like this. We have like a coded codable concept code for the pregnancy status, yes, no, or unknown kind of stuff. So we have like a message bundle here, and if we see a transaction bundle, so I'm gonna do the same thing here, JSON, convert that to JSON, and then make it prettify. All right, so we have like transaction. Basically, it's almost like identical, except the this one has at the end it has a request method. So this one can tell a FHIR server that this will be post. So the server needs to create this patient. All right, so this is all we have for the converter. Thank you.
That was great. Thank you, Myung. If you're interested in learning more or connecting with us in general, please feel free to reach us via Whova, or you can email us directly at the following emails. Now we would like to open up for questions. Thank you so much for tuning into our session. All right. Well, hello everyone again. Thank you so much for tuning in and listening to our talk. If you have questions, please feel free to post in the Q&A slot on Whova. I would likely read out the questions and have Myung answer. And then just in case you do not have any questions, I did want to get us started with a few questions of my own, just to get the conversation rolling. If you would like to, you can feel free to post in a Q&A slot if you have ever heard of MMGs before, and if so, could you share if you've used them? And another question would be, has anyone used HL7v2 messaging? I know that the topic of this conference, or the Dev Days, is usually centered around FHIR, but it's always interesting to see what other interoperable standards are being used out there to date. And if you have used V2, in what capacity would you like to share that you've used them in? And as well, if you like to share if you are using V2 or have in the past, if you've had any, I guess, experience mapping HL7v2 messaging to FHIR, and if you have, what types of, I guess, constraints or issues did you run into, if any at all? So I'll just kind of put myself on mute here and check out the Q&A. All right, so we have one question, and Myung, if you would like to unmute, we can kind of banter here. So, was questionnaire an option? And I would like to preliminarily say yes, it was. But Myung, if you'd like to go in detail about the work that
it was actually it was actually a solid yes, and actually that's the first resource that we evaluated. It does have all the capability to have basically all the questions and questions in the MMG, and you can actually provide all the answers there. One issue was the questionnaire is still kind of not very familiar with the people, especially like the data that is being generated by EHR. So because one of our plan was the upstream data, which is the EHR data, we want to somehow integrate those data as well into our like IG. And once it is great resource that we can put all those question and answer stuff, but it's not really convenient if it comes down to the analytic people, someone who wants to view it. It's sometimes a lot easier that you have like a list of observations with very specific to the questions, and you know, and work with another resources that contains some data as a supporting material. So what we did is we tried to use the like observation and condition patient, and you know, like a specimen in case of we have the lab data in there. We kind of use the kind of basic file resources as much as possible. And then those, so now when our plan is, you know, how we're going to handle like really basic questions that is not really appropriate to have like a file resource to handle that. We may use a questionnaire. We're kind of thinking that whether we use a questionnaire or use like observation as our default. So we are kind of still having like internal discussion, but we consider it as an option, but we believe that the question is not, it doesn't really fit well for the users in the CDC programs.
Right. So it's not ruled out as part of our research. As Myung said, it's something that we're continuing to test out as we go, even though preliminarily in our converter, we've kind of just thought that it would not be the best fit for now. So we do have two more questions that we would likely, and thank you, Myung, answer either in the chat. And that is, for the data flowing to the CDC, is the ELR from laboratories or data from the state EPI? And then the third is, how did you deal with V2 user-defined data sets mapping to a required or extensible value set in FHIR An example is PV1-2. So we'll follow up with those questions via chat. Thank you so much.
And thank you, Tia and Myung, for your session today. The answers to the questions can be seen in Whova, as the presenters will have an opportunity to continue to answer questions after the session has completed. The recordings will be available by tomorrow. And be sure to rate the session by clicking on the link in Whova. Thanks very much. Have a great day.